Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers, and today we have a conversation about polio and polio vaccines. Dr. Bill Moss, Executive Director of the Johns Hopkins International Vaccine Access Center and an expert in vaccines and vaccine-preventable diseases, talks about this incredibly dangerous disease and the vaccines that can not only prevent it, but that have actually helped to eradicate it from most of the world. Let's listen. Dr. Bill Moss, thank you so much for returning to Public Health on Call. Today we're talking about polio. So can you help us understand just how dangerous polio is?
Yes, thank you, Lindsay, and great to be back. And polio has been in the news a lot recently, so it's very important that we talk about this. So polio is an infectious disease caused by polioviruses, and there are three types of polioviruses. And it's an infectious disease that's transmitted through what we call the fecal oral route. So it goes into the mouth, into the gut, comes out the other end, and that's how it's transmitted through contaminated water or food or even hands from one person to the next. Many people who acquire poliovirus infections, particularly early in childhood, will have a relatively minor illness. They'll have a fever, sometimes will have a flu-like illness. More seriously, they'll get what we call an aseptic meningitis, which really just means some inflammation around the brain, around the meninges, that's not due to a bacterial infection. But what we really worry about, and it only occurs in about 1 in 100, maybe 1 in 200 infected people, is the paralytic form of the disease. So that's the real severe disease, and that can lead to lifelong disability, a difficulty walking. If it affects the spinal cord high up, it can impact breathing, and it can lead to death.
You mentioned that there are three types. Can all three lead to this serious form of the disease?
Yes, all three of the different polioviruses, poliovirus 1, 2, and 3, can cause paralytic disease. But it's worth talking a little bit about those viruses because poliovirus type 2 and type 3 have actually been eradicated, the wild-type polioviruses. So we don't see infections anymore due to wild-type polioviruses type 2 and 3. Type 2 was declared eradicated in 2015, type 3 in 2019, although even the last case of paralytic disease due to wild-type poliovirus 2 was last seen in India in 1999, but all three can cause disease.
When you say eradicated, can you define what that means? And is this everywhere around the world?
Yes. So we use the term eradication to describe when there's no longer naturally circulating pathogen, whether it's a virus or bacteria, around the world. We tend to use the word eliminated when referring to a specific geographic area. So, for example, we would say smallpox is eradicated, polio is eliminated in the United States or Americas.
And break down what you mean when you say wild type.
Yes. So this is an important distinction to understand, and we can talk about this in more detail. But in addition to the wild-type polioviruses, that's the natural poliovirus. And as I said, types 2 and 3 have been eradicated. Type 1 of the wild-type poliovirus is circulating right now only in 2 countries, Afghanistan and Pakistan. But there are what we call circulating vaccine-derived polioviruses, and we can talk more about what those are. But those are viruses that are derived from the oral polio vaccine that's now circulating in about 45 countries around the world, at least in 2024. It changes year to year where we find those viruses, and those can actually be types 1, 2, or 3. They're most commonly right now type 2, but all three types of the circulating vaccine-derived polioviruses can cause disease now.
And that's what I'd like to get into for the crux of this episode. But just to make sure that we have a full understanding of
Yes.
poliovirus, in these countries where you do have the wild types continuing to circulate, someone goes to the doctor. Are they tested for polio? How do they know when they see it? How does that happen?
Yeah, so the way surveillance for polio takes place, there are a couple of different ways. The most common way is just looking for people who develop paralytic disease. It's called acute flaccid paralysis surveillance. And when kind of an acute onset of paralysis occurs in the proper context, say in Afghanistan or Pakistan, and it's a suspected polio case, then typically the stool from that individual will be sent to a laboratory, and poliovirus, they'll attempt to culture poliovirus from that. We can also use molecular methods to detect polioviruses. Another common surveillance system that's more recent is the use of wastewater surveillance. And people may have heard about wastewater surveillance for COVID, for example, SARS-CoV-2. And it was also in the news when we had that poliovirus case here in the United States in New York in 2022. So that's where molecular methods are used on wastewater or wastewater treatment plants to detect polioviruses.
And is this primarily among children it's children that are getting infected?
Yes, across the globe, it's mainly children, but susceptible adults can also get polio and get paralytic disease. So adults are not, unless they've been properly vaccinated and immunized, susceptible adults can also get paralytic disease. But globally, it's largely a disease of children.
And if you've had polio as a child, and let's say you had a milder case and you got over it, are you then immune for life?
Well, you would be immune if you weren't vaccinated. You would be immune to that serotype, that type of poliovirus. And as I said, now, it's really type 1 that's circulating. So if someone did get infected with wild type poliovirus 1, they would be immune from further infections. It does confer lifelong immunity.
Okay. It's important to kind of set the scene here so that we know where it's circulating, we know how we find it, we know who is predominantly most at risk here. Because now I want to get to what you mentioned before, which is we have a version of polio that can be circulating where there's vaccinations happening. So can you describe what that means?
Yes. So maybe we can talk first about the two broad different types of polio vaccines. So the first to be developed was actually back here in the United States in 1955, is the inactivated polio virus vaccine. That was developed by Jonas Salk. It's hard for us to imagine the delight and celebrations that took place here in the United States in 1955 when the results of the trial were announced. But here in the United States, polio was a dreaded, feared disease in the mid-1950s, and people were just so relieved to hear about that vaccine. So that's the inactivated vaccine. We call it a trivalent vaccine because it's effective against each of the three types of polioviruses. Several years later, in the early 60s, Albert Sabin developed the oral polio vaccine, or OPV, IPV versus OPV, the oral polio vaccine. Also was originally a trivalent vaccine against all three types, but that's a different type of vaccine. That's what we call an attenuated viral vaccine. Many other attenuated viral vaccines are measles vaccines, are rubella, mumps. These are all viruses that have been weakened by passaging them, growing them in non-human cells. They adapt to those cells. And then when they're put back in humans, they induce an effective immune response, but don't cause disease. Or typically don't cause disease. That's what we'll talk about. And so those vaccines, what's the big advantage of the oral polio vaccine is that it can be administered orally. And that's what many people may remember about polio vaccines, 2 drops of this liquid in the mouth. It's kind of mimicking the way wild-type polioviruses infect individuals through our intestinal system. And because it's just a couple drops, really many people can be trained to deliver that vaccine. It's very easy to deliver. It doesn't require a needle and syringe, so you don't need trained healthcare workers. You don't have the medical waste problems. Because of that ease of delivery, countries adopted the oral polio vaccine, and that became the basis of the global polio eradication effort. And that vaccine was very highly successful and has reduced the number of polio cases by more than 99%. People say 99.9% reduction in the global incidence of polio as a consequence of using the oral polio vaccine. But it does have an important drawback, and that is that these viruses that have been attenuated can mutate back, can develop the ability to mutate back and cause disease. And that's now a huge concern. It has been a concern for a long time. So here in the United States, for example, for a number of years, there were more paralytic cases caused by the vaccine. It's called vaccine-associated paralytic poliomyelitis, or VAP. And so we switched from the oral polio vaccine to the inactivated vaccine here in the United States in the year 2000. So it's been 25 years here in the United States since we've used that oral polio vaccine. But many countries around the world had continued to use this, and it's particularly that type 2. It can happen with all three types, but it's particularly that type 2 that has a propensity to revert back to that neurovirulent form, that neurologically virulent form, and cause paralysis. And so that's what we're seeing outbreaks of, particularly type 2 circulating vaccine-derived polioviruses, particularly throughout many countries in Africa and in Southeast Asia.
Help us understand, so this is a risk-benefit situation, yes. It sounds like. So help us, first of all, put in perspective, how often does it happen that the oral attenuated version of this vaccine can revert?
Yes. So it is quite rare, and it can happen in an individual where it's called vaccine-associated paralytic poliomyelitis, and then in situations, so it's hard to give kind of a single number because it's very context-specific, but in situations where immunization rates are low against polio, so you have susceptible children, and where sanitation is poor, so that facilitates this fecal-oral transmission of polioviruses. That's where you tend to see these outbreaks of circulating vaccine-derived polioviruses. So it's really kind of in that context is which we see it. It's still very rare. To put it, the benefits over the course of the past several decades where we've seen this 99.9% reduction in polio cases, the benefits have far outweighed the risk. But as wild-type polioviruses become rarer and rarer, and like I said, right now they're only limited to Afghanistan and Pakistan, then that risk-benefit calculus changes. That's why the United States switched to the inactivated polio vaccine in 2000. And so back in 2016, the World Health Organization and partners recognized that risk-benefit had changed. And so here we get into a little bit more of the nuances in other vaccines. But what they recommended in 2016 is what is often called the switch. And it involved two things: switching from the trivalent oral polio vaccine to a bivalent oral polio vaccine that just had types 1 and 3, and introducing a single dose of the inactivated polio vaccine. So many countries, let's say in sub-Saharan Africa, use a regimen where they're giving the bivalent oral polio vaccine at 1, 2, and 3 months of age. And then on that last dose, they're also giving the inactivated polio vaccine. So it's that inactivated polio vaccine that's going to provide that protection against type 2, and then the bivalent has the protection against 1 and 3, as well as the inactivated polio vaccine. Now, there's one more nuance, Lindsay. Several years ago, there's what was developed, a novel oral polio virus vaccine 2. What the researchers did is they made some deliberate genetic changes to the poliovirus so that it was less likely to become virulent. So novel OPV2. That vaccine is now widely used to help control some of these outbreaks of the circulating vaccine-derived poliovirus 2. The risk isn't zero. It's not impossible for it to become neurovirulent, but it's a kind of a modified OPV2 that has a much lower risk of becoming neurovirulent. So that's become a new tool in our fight against polio and hopefully eventual eradication of polio.
And the novel version, is that to eventually replace the oral attenuated version altogether, or is it in addition to?
Yeah, so it's to replace it. Basically, in the world now, no one's using the original OPV2, oral polio vaccine 2, because they've switched to this bivalent oral polio vaccine that's just 1 and 3, and then the novel oral polio vaccine for the type 2. But just to highlight, again, that the IPV that children get now still is against all three serotypes. So that an inactivated polio vaccine is going to provide some protection against that type 2. And there's no risk of the IPV causing paralytic disease because it's a killed virus.
Now, you mentioned, and I just want to clarify one point, you mentioned earlier on that there was a case in the United States in the last decade or so. Can you tell us the particulars of that situation?
Yes, that was a case it was an importation from another country of one of these circulating vaccine-derived polioviruses. So it wasn't the wild type, it wasn't the type of virus in Afghanistan or Pakistan that then ended up causing paralytic disease in a community. It was an Orthodox Jewish community in New York, vaccine coverage against polio. So you had a susceptible population because of low vaccine coverage. And then you had an importation of one of these circulating vaccine-derived polioviruses. And so that one case was identified. But one important thing for people to remember is that, and I alluded to this before, that only 1 in 100, 1 in 200 infections with poliovirus cause paralytic disease. So when you see a paralytic case, that means that oftentimes it can mean that a lot more people are actually infected. And what happened in the New York area was that they did identify polioviruses, these circulating vaccine-derived polioviruses, in the wastewater in a larger geographic area in New York.
This is all really helpful context to bring us to where we are today, which is, there are some really loud voices that are claiming that the polio vaccine can cause polio. And as we've learned, it can, but it's extremely rare. And there are all sorts of things being done to kind of mitigate that risk.
Yes.
But there's a movement towards, number one, not vaccinating at all, which is concerning, especially, the case that you just illustrated for us. Yeah. And secondly, there are efforts, for example, Aaron Siri, the lawyer, has petitioned the FDA to revoke approval of the vaccine.
Yes.
So can you put these things in a little bit of context?
Yes. So first, I want to emphasize again that for the past 25 years here in the United States, we've used the inactivated polio vaccine, the IPV, and there's no risk of that causing paralytic disease. So people here in the United States should feel very comfortable about the safety of the IPV vaccine. And so, but as with all infectious diseases, if there's an outbreak anywhere, it puts others at risk. So if vaccine coverage against polio occurs here in the United States, and particularly, what's really important as we think about this as infectious disease epidemiologists is the clustering of susceptibles. That's what's really important. If it's a random person here and there, then it's very unlikely that you're going to get an outbreak, almost impossible. But that's not how susceptibility it tends to kind of cluster in communities, in groups of people who, for one reason or another, whether it's religious reasons, philosophical reasons, or have some concerns about vaccines or vaccine skepticism, if they're living together, then you create these communities of susceptibility. And then if there's an introduction from another country where these viruses are circulating, then you're going to have at least a risk of an outbreak. Now, I will say, Lindsay, here in the United States, because we have very good sanitation systems, and so we tend to obviously see polio outbreaks nowadays in areas with poor sanitation. But again, going back in the 1950s and 1930s, 40s, 50s here in the United States, polio was a feared disease across the country. Parents would not allow children to go into swimming pools, for example, because of risk of exposure. So it can happen, even with, reasonably good sanitation systems. You can get spread of polioviruses, but it is mitigated in part by having good sanitary systems as well as high vaccination coverage.
I was going to ask you, I mean, it's unacceptable for any child to get to the point of paralytic disease when we have such good vaccines. I mean, that is the goal, is to prevent that. But given what we know about vaccination rates now, how quickly could we be in a truly precarious situation if vaccination rates drop in the U.S.? I mean, when you've talked about, we have better sanitation systems, but I mean, it seems like this could happen quite quickly where we could see huge outbreaks.
Yeah, we would probably see with polio. So I'm much more worried about measles outbreaks in the United States because that's transmitted by the respiratory route, much more infectious. It's very easy to get large measles outbreaks. Polio, I think what we would see if immunization coverage rates continue to decline in the United States, we'd probably see we could see some focal outbreaks where you have this kind of clustering of susceptible individuals. But I completely agree with you. Just to have a single case of a child paralyzed by polio in the United States would be enormously tragic and completely preventable. I mean, one of the things when I teach about polio, it's a very visible disease. And because in the days where it was occurring here in the United States, you could see people with leg braces, for example, and identify those as victims of polio. People may have seen pictures of the iron lung. So the iron lung, and there were hospital wards full of these iron lungs. They're negative pressure respirators. So when polio, which it can affect the muscles of respiration, people can't breathe on their own because they're paralyzed. And so they require this assisted, and basically they live in these iron lungs. Just earlier last year, in March of 2024, a man died who had lived in an iron lung for 72 years. It's just hard to imagine. He was an amazing person. He got a law degree. He wrote a book. He was a TikTok star, but he lived confined in an iron lung for 72 years. And we do not want to see that again.
Last question for you. This is a really complicated conversation because, I think there's a science conversation here, and what you alluded to earlier is a philosophical conversation. What do you want people to know?
I want people to know that vaccines make diseases, when used effectively, disappear. And then we forget about them. We forget about the importance of these diseases. And polio is a great example. I've said people were so afraid of polio in this country in the first half of the 20th century, and they didn't have to fear that anymore. And that's all because of polio vaccines. And, to look at the numbers of polio cases here in the United States over the 20th century, you see all these spikes in the first half, and then there's nothing in the second half. And that's because of vaccines. But we can't take that success for granted, because it can come back. Until a disease is eradicated, we need to continue our efforts. And the inactivated polio vaccine that's used in this country is a very, very safe vaccine. We do have problems with the oral polio vaccine, and probably as a global community, reacted too late for that, made that switch too late. And that's very unfortunate and very tragic. But the inactivated polio vaccine that we use in this country is very safe and will prevent us from going back to those days where parents have to fear that their healthy child could be paralyzed the next day.
Dr. Bill Moss, thank you so much for giving us all of this really important context.
Thank you very much, Lindsay.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Fernandez-Cesiri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.